Good morning. Thank you for all attending the CTN virtual meeting. The title of my
It's at 100.
presentation is Effects of Folate-Deficient Diet on Fetal Development when Pregnant Mice are Exposed to
What?
dolutegravir in combination with tenofovir and emtricitabine. Before I begin, I do not have an affiliation, financial or otherwise, with any for-profit or non-for-profit organizations. In 2016, dolutegravir, an integrase strand transfer inhibitor, became the WHO first-line regimen for all people living with HIV. Although caution was noted about the lack of sufficient data of dolutegravir use in pregnancy. In 2018 and late in 2019, a study in Botswana reported a higher incidence of neural tube defects in pregnant women who started treatment with dolutegravir from conception. Surveillance is ongoing and new data from women exposed to dolutegravir are consistently being collected. However, many of these studies are limited by small size and the number of pregnant women exposed to dolutegravir from conception. The complications from the same patient may be reported in multiple cohorts. Most cohorts include live births, but occurrence of neural tube defects among stillbirths and aborted fetuses may not have been reported or recorded. As we know, folic acid, which is known to prevent the vast majority of neural tube defect cases, its function could be implicated by dolutegravir use, altering folate's biological role and its metabolism. Our body transforms dietary folic acid into folate, which mediates normal neural tube development, and therefore folate is essential during early stages of human development, especially during pregnancy. Low levels of folate are associated with several other birth defects, and therefore periconceptional administration of folic acid helps prevent the occurrence and recurrence of many congenital anomalies. During pregnancy, this vitamin plays an essential role in embryonic development, where its requirement increases and is critical for maternal health and fetal development, which is 400 to 800 mcg per day. Although dolutegravir is shown to be safe, well tolerated, and an effective treatment for HIV, its safety in pregnancy is not well established, and additional studies are warranted. The combination regimen of dolutegravir plus tenofovir emtricitabine or TDF-FTC is a commonly used regimen globally, including in pregnancy. Animal studies, including reproductive toxicity studies, are part of the regulatory process of new drug approvals. Regulatory agencies generally require toxicity studies, including reproductive and fetotoxicity studies, to be conducted in two or more animal species. Reproductive toxicity studies for dolutegravir were conducted on rats and rabbits, and while some defects were reported, they were not deemed to be dolutegravir related. As is customary, these studies were performed with doses of dolutegravir yielding higher than clinically relevant plasma levels, and dolutegravir was not administered throughout the entire pregnancy, but only for specific windows representing specific reproductive aspects. Also, dolutegravir was not administered as part of a combination regimen. Nutritional animal models aid in understanding human diseases, and studies are limited to predict dolutegravir plus tenofovir emtricitabine teratogenic effects in the presence of a folate sufficient or a deficient diet. C57 black 6 mice are resistant to neural tube defects and serve as a background strain for many of the mutants associated with neural tube defects. As such, we chose to perform fetotoxicity studies in C57 black 6 mice fed on a folate sufficient and a deficient diet treated with dolutegravir plus tenofovir emtricitabine from the time of conception, with a dose yielding plasma levels similar to those seen in pregnant women. Our aim is to shed insight on whether folate status modifies the risk of neural tube defects and other birth defects associated with dolutegravir plus tenofovir and emtricitabine. This could have implications for folate supplementation recommendations for women taking dolutegravir and contemplating pregnancy and folate fortification programs at the country level. We hypothesize that perinatal dolutegravir plus tenofovir emtricitabine exposure at a clinically relevant dose may alter fetal development, and the absence of folate will increase the incidence rate of neural tube defects and other congenital anomalies with dolutegravir plus tenofovir emtricitabine exposure from conception. In our treatment regime schematic, we have two diets: folic acid sufficient and folic acid deficient diets. In the first schematic, C57 black 6 mice were fed ad libitum on the folic acid sufficient diet, identified in the brown color, and were allowed to mate. On the day of the plug, identified by embryonic day 0.5, we randomly assigned mice to either the dolutegravir plus tenofovir emtricitabine arm or the control arm, which is water, both administered daily by oral gavage. Dolutegravir plus tenofovir emtricitabine was administered at a dose yielding clinically relevant plasma levels of 3000 nanogram per ml. In the second schematic, C57 black 6 mice were fed ad libitum on the folic acid deficient diet for 2 weeks, identified in the orange color, and then were allowed to mate. The pregnant mice were still on the diet during the pregnancy period. On the day of the plug, identified by day 0.5, we randomly assigned mice to either the dolutegravir plus tenofovir emtricitabine arm or the control arm, which is water, both administered daily by oral gavage. On embryonic day 15.5, dams were sacrificed and fetuses were harvested, photographed, and fixed for further histopathological analysis. Litter size, fetal viability, and the number of resorptions and fetal and placenta weight were also recorded. Maternal weight gain during pregnancy was recorded as well. In the folic acid sufficient diet, the number of control litters were 91, yielding 747 fetuses, and dolutegravir plus tenofovir emtricitabine treated are 150 dams yielding 1174 fetuses. In the folic acid deficient diet arm, the number of control litters are 71, yielding 526 fetuses, and dolutegravir plus tenofovir emtricitabine treated arm are 101 dams yielding 740 fetuses. The studies are not yet published and we are still collecting data. Each fetus was evaluated for gross anomalies by reviewers blinded to treatment allocation. We looked for anomalies in the brain, neural tube, abdomen, craniofacial, eye, limb defects, skin, tail, and body symmetrical defects. We also scored fetuses for bleeding and vascular defects, edema, liver size, and growth retardation. As well as we scored fetus for body turning defects. In the dams fed folic acid sufficient diet, we found no neural tube defects in the control group. But 5 fetuses in the treatment group had neural tube defects for a rate of 0.43%. Each fetus with the neural tube defects was from a different litter, giving a litter rate for neural tube defects of 3.3% and an odds ratio of 6.92. The first fetus was non-viable and displayed exencephaly with an amount of protruding brain tissue and an absence of top skull. It was growth retarded, hemorrhagic, and had a kinked tail. The second fetus was non-viable, demonstrated exencephaly and holoprosencephaly, where the forebrain fails to develop into two hemispheres. It displayed bilateral anophthalmia and mandible aplasia. The third fetus was as well non-viable, growth retarded, and displayed forebrain angenesis as seen in anencephaly. Forebrain angenesis occurs when the rostral head region end of the neural tube fails to close. The last two fetuses were viable and both displayed spinal bifida, which was further confirmed by histopathological analysis via H&E staining. It is important to note that several fetuses from the dams fed on the folic acid sufficient and folic acid deficient diet displayed anomalies similar in both groups. Compared to the control, more dolutegravir plus tenofovir emtricitabine treated fetuses had anophthalmia and microphthalmia. Anophthalmia is a complete absence of an eye and the ocular tissue is missing from the orbit, while with microphthalmia the ocular tissue is present but is abnormally small. The defects were either unilateral or bilateral. Mandibular defects were also seen in the dolutegravir plus tenofovir emtricitabine group. In this image, You can see a treated fetus with an abnormal shortening of the lower jaw compared to the control. We observed fetuses that had severe edema and vascular bleeds displaying a petechia-like pattern. Fetuses were also hemorrhagic and some fetuses displayed cranial and spinal bleeding patterns. We found that the eye defects, edema, and vascular bleeds, including the cranial and spinal bleeds, were significantly high in the treated group compared to the control, fed on a folic acid sufficient diet. Fetuses in the dolutegravir plus tenofovir emtricitabine group, fed on the folic acid sufficient diet, also displayed a higher rate of enlarged liver compared to the control. Although we found high rates of enlarged liver, this did not quite reach significance. We as well saw hind limb defects such as shortening of the limb. Tail defects were also observed where we found fetuses with kinked, curly, and flexed tail. Hind limb and tail defects were statistically similar between groups. Abdominal defects were also found in the fetuses but were not significant. We found that many fetuses displayed vascular defects, and these were significantly more common in the dolutegravir plus tenofovir emtricitabine arm fed on the folic acid sufficient diet. Histopathological analysis using H&E staining showed that fetuses with severe edema displayed distension of the back with an evidence of vascular fragility and vascular leakage in the extracellular matrix. Accordingly, fetuses from the dolutegravir plus tenofovir emtricitabine arm were also showing severe hemorrhage in the pericardial and abdominal cavity compared to the control fetuses. These data suggest that treatment to dolutegravir plus tenofovir emtricitabine may predispose fetuses to defects related to vascular stability. In the dams fed on the folic acid deficient diet treated with dolutegravir plus tenofovir emtricitabine, we observed neural tube defects and an increased incidence of turning defects that we never saw in the treated folic acid sufficient group. This is the control fetus shown in the right, left, anterior, and posterior plane. The first fetus here displays encephalocele, which forms as a result when the bones of the skull do not close completely. This causes a gap through which the cerebral spinal fluid, brain tissue, and the membrane that covers the brain can protrude into a sac-like formation. The other three fetuses shown exhibit extreme turning defects, where we see the organs protruding, abnormal turning, and an extreme lower abdominal malformations. We saw an increase in the incidence in the left and right turning defects, defects in the anterior, posterior, and dorsoventral turning, and these defects suggest notochordal and cardiovascular defects. These fetuses are currently being scanned to examine them closely. Here is a summary of our findings. Our data suggests that fetal anomalies were more common in fetuses exposed to the clinically relevant doses of dolutegravir, supporting a link between dolutegravir plus tenofovir emtricitabine use in pregnancy and adverse fetal outcomes. Neural tube defects were rare but more frequent in the dolutegravir plus tenofovir emtricitabine group compared to the control. The neural tube defect rate of 0.47% in the dolutegravir plus tenofovir emtricitabine group fed on the folic acid sufficient diet were similar to the neural tube defect rate seen in the Botswana study. We plan to examine the congenital anomalies following dolutegravir plus tenofovir emtricitabine exposure from conception in the presence of the folic acid deficient diet. We're currently investigating the pathophysiology of edema formation and its potential link to petechia and hemorrhagic-like vasculopathy. We're also looking forward into the pathophysiology of turning defects as we saw in the folic acid deficient group. Future studies are also focused on determining the rate of congenital anomalies following other entities' exposure from conception. I would like to thank CTN for providing this virtual platform to present my findings and my viewers as well. I would like to thank the Servidus team, all the funding agencies, and collaborators.